Joining. Emily?
Why don't we call out Emily?
My name's Emily Karp. I'm from Lansing, Michigan, and I'm a BHC here at Sparrow Family Medicine. It's a family medicine residency clinic. So I did my internship in social work about 2-3 years ago when they were starting to implement collaborative care. So I got to see that whole process. And now I am working under a grant through the Michigan Health Endowment Fund to set up collaborative care at a few clinics around the state that's specific to perinatal depression. So I really just zoomed in today just to listen and learn more, kind of new to this field.
Okay, are you working with Karen Blackman?
Yes, yep.
Yes, I have a soft spot for, I'm from Michigan. I was born and raised in Ann Arbor.
Okay,
So
great.
And I went to medical school in Detroit, so I have a soft spot for Michigan.
Okay, yeah. We like it.
Let's see, who's next? Kevin.
Hi, everybody. My name is Kevin Radine. I am a mental health counselor by training, also a PhD candidate, though, at Rutgers University. I've spent most of my career in college mental health settings, actually integrated, I should say, college physical and mental health settings. And so it's kind of what brought me to wanting to study integrated college health. Specifically, I'm looking at my program at the PCBH model and embedding a BHC in the physical medicine of a college health center. And so
Can I ask where?
Yeah, sure. Right now I work at RPI, Rensselaer Polytechnic Institute. It's actually in Troy, New York. And then I'm studying at Rutgers, and so that's kind of really what brings me to the Zoom today, both professionally and then in my PhD work, on looking at collaborative care and integrated health. So
it's super interesting, Kevin. I've been kind of had this fly in my bonnet about college mental health for some years now. When I was doing the learning collaborative that I met Patty at, there were any number of college mental health psychiatrists who came through, and every one of them were like, wouldn't this be a great idea to do this in college mental health, where there's resource limitations and where there's and there's a funding model often that would lend itself to non-billed service. Right. And I always thought it was the best idea ever, and I could never get any traction. It's been very frustrating to me, and I don't actually work in one of those settings, so I know a lot of people who do.
Yeah.
Anyway, I still think it's a great idea.
Absolutely.
So, yeah.
I agree. Thank you.
Yeah. Let's see here. Diana actually chatted in. She's a BHC for a collaborative care program in Colorado, and implementation is the issue of the day. Anything else, Diana? Okay. Welcome, Eric.
Good morning, everybody. Eric Osland, founder and managing partner of a group out here in Arizona called Evolved MD. Been a big fan of Patty's for a long time, so I tend to tune in on these, but we are an organization focused on integrating behavioral health services in primary care. Right now here in Arizona, we have 21 sites that are all embedded behavioral health providers under the psychiatric collaborative care model, and some really exciting growth in the year ahead. We're opening 40 sites over the next 12 months. So by the end of 2022, we'll have roughly 60 sites throughout Arizona, Utah, and some other states.
What's the name of your organization, Eric?
Evolved MD.
Evolved. All right. Welcome.
Thank you.
Let's see here. Lisa. Hi, Lisa.
Hello. I am a psychiatrist working at Lundell Christian Health Center on the west side of Chicago. I've been building an integrated program, robust behavioral health department that's already integrated, so kind of working to add psychiatry with that. And yeah, so it's a little broader than collaborative care, and we focus a little on more severe mental illness. So it's, yeah, but always interested in learning more and connecting with people.
Yeah, Yeah, so that's actually something that that I'm really interested in, is kind of a broader application. As is Dr. Williams, who is chewing over there on the right side of my screen. I'll move on. I'll come back to you, Mark. Katrine? Oh, she's connecting. Well, maybe we'll come back to her. And then somebody's at 8. I don't have my glasses. I don't have my cheaters on, but somebody's at a phone number 858. Is it? Very code 858. Yes. Okay, well, chat in, and Katrina as well. And hi, Mark.
Hi, what are we just doing intro?
We're just saying hi, introducing ourselves.
Yeah, hi. Mark Williams, sorry I was a little late. I'm a psychiatrist at Mayo in Rochester, where we have an evolving effort to do integrated behavioral health that always needs to improve. We have a lot of care coordination going on and some embedded psychotherapy, but lots of room to grow because we have about 800,000 adults across 5 states. So there's plenty of room to improve, and learning from each other is what's fun.
So welcome, Mark. Mark is always a hero of mine in terms of implementation. So if we have implementation issues, we'll foist them on him. And last but not least, Liana Edwards.
Hi, I was just messaging Patty. Let's see. Oh, we just celebrated Jackie Hahn on staff. It's her birthday today. So excuse my background. But I'm the admin assistant with CFHA. So it just happened on.
Oh, okay.
Anything.
Okay, nice to meet you.
Just to check it out. But nice to meet you,
Okie doke. Okie doke. So Patty asked me to come on, and she promised me this would be very casual. And by golly, it's going to be if I have to kill myself. So what I'd like to talk about is I want to talk about what's of interest to you, and maybe some things that you might not know about that we're up to. I think that I will start by just introducing myself and a little bit about what I do and where I work. I'm John Kern. I'm a psychiatrist. At the moment, I am on the faculty of the University of Washington, where I've been for about 5 years. I work at the Ames Center, and what the Ames Center does is, I'm going to read you our mission statement. Our purpose is to inspire, that was my word, inspire providers, researchers, and decision makers to transform healthcare and improve patient outcomes. We accomplish this by translating and researching evidence-based approaches to behavioral health integration. So what we do at Ames, sometimes people say, can I come out to Ames and see how your program works? We don't really do a ton of actual service provision ourselves. That's not what we do. Most of our work is either research, which these days is mostly, initially the research was organized around, demonstrating the effectiveness of, or exploring whether or not collaborative care was effective, and for sort of the core activities of depression and anxiety. And in recent years, it's become more implementation focused and more focused on an expanded scope. So there'll be, there's research in the hopper these days about bipolar disorder and PTSD and perinatal populations, and a lot of work on implementation. Trying to figure out, because one of the things we've learned is that it's not so easy to implement. There's a lot of moving parts. It's a relatively complex animal, and it's not a plug and play activity. And so trying to figure out how to move past some of the complexities, the difficulties that have plagued some of the implementations around the country is sort of what we've been spending a lot of time thinking about these days. It's kind of sad in a way, we've been at this now for over 20 years, and there's all this research that demonstrates that it works, but go try and set it up. It's not so easy. So I've been at Ames about 5 years doing that kind of work. Most of my work has to do with creating teaching materials and training materials, and providing training and implementation support to organizations that are doing this kind of work. I also work about a third time as a consultant psychiatrist for a federally qualified health center system in Seattle. So, which is fun. I'm located these days, or as always, in Chicago. And so I've been on the faculty at UW and working with Seattle-based organizations. I used to go out there a lot more than I do now, but I was an experiment. I was experimenting in remote work, mostly because I was too old to move, and it seems to have worked out pretty well. I think it just underlines the fact that you can, especially as a psychiatric consultant, function completely seamlessly. The only thing I miss is actually being able to go and press the flesh and see people and rub elbows with the PCPs, because I think that's really super helpful and important. So how did I get to be at Ames? Prior to that, I was 27 years and a community mental health psychiatrist in beautiful, lovely Northwest Indiana. So if any of you are familiar with the Chicago area, you know that Northwest Indiana, Lisa will know this, is kind of the industrial armpit of Chicago. And so it's a blighted, underserved, disparity area but it was a great place to work. And so I was the medical director of a big community mental health center, and we set up a couple different collaborative care programs, one with a partner FQ and one with eventually we became a federally qualified health center. One of my other hats is I became interested in the medical care of people with SMI, and in that form of what's called reverse integration, which term I don't like. It sounds like left-handed complement, but that's one of the things that we worked on, and that's how we ended up becoming a federally qualified health center, because we just couldn't link up adequately with primary care for.
He's not here, Ness.
For folks, and
gone to doctor, I think.
Yeah. So yeah, and so that's one of the things I'm going to talk about, because I'm still doing some of that work. For when I came to Ames, that was one of the things I brought with me, and so I'm still. If anybody's interested in that kind of work, raise your hand. If you're not, I can talk about something else. But okay, Kevin. So that's one of the things I've been working on. One of the cool things about the place where I came from that I'm still a little bit connected with is when I was there, we started the process of applying for a psychiatric residency, which, as you may know, takes a while. And so it's only just coming to, we started this 7-8 years ago, and before I left, and it's just coming to fruition. That residency will open next year, a year from now, or a year from July. And so it's going to be 4 spots. And the cool thing about, I think this is really cool, even though it's not mine anymore. The whole thing is going to be done in-house. And so they'll do their inpatient psych on our inpatient unit. We run an inpatient unit. They'll do their medicine in the FQ. They'll do their collaborative care in the FQ. They'll do their SMI psychiatry in the mental health center. And so they may have to farm out a little bit for like neurology but for the most part, it'll be devoted toward creating people who are prepared to work in the team-based setting in integrated care in both directions. So I just think that's really, I'm excited to see how that will go, and I'll have some role in that. So that's fun. That's cool. Let's see here. So we talked about what goes on in Ames. Talked about, and so the other thing that I'm interested in these days, and that overlaps with some of what some of you have talked about. I've talked about the issue of what we call, for shorthand, PC and BH, primary care and behavioral health, or the medical care of people with SMI. And so increasingly, it seems to me that starts to overlap with the care of an expanded population. There's this expanded population. I don't know if it's expanded or if it's always been there, but people who are seen in primary care who come in with not conveniently with quote unquote primary care psychiatry problems, but with every damn thing in the world. And in some places, you can move them along and you can refer them. And in some places you cannot, or it's not easy, or it's not well accepted. And in some places, we've had the experience of actually having a referral source, and the patients, referring the patients out to them, and the patients come back and they say, we'd rather be treated by your program with your behavioral health provider because they do a better job. And so, that makes you feel like, oh, we're doing a good job. But on the other hand, it's not so good in terms of being able to provide it, use all of the resources of a community to provide access. So I've been spending a lot of time thinking about kind of the overlap of that, of, you know, so the care of people with more serious and complex psychiatric illness, and also the issue of the care of people with complex multi-disorder medical problems, and that sort of overlaps with, you know, primary psychiatry, and that sort of overlaps with the use of teams providing case management for complex disorders, and that overlaps with, you know, global funding. And so there's this whole, I had a confusing conversation, confusing because of me, not because of Mark, but with Mark about this recently, trying to figure out how we can leverage the different model of taking care of patients to actually meet the needs of the population that's already out there. Another way of thinking of this is like, if you're going to like, you know, erase the whole blackboard of the provision of mental health for the most part, and say, okay, we're going to design it from scratch more rationally, what would you do? And, you know, if you have some time to think about it, you know, how would you set that up, and how would you use this, what seems to have been very useful and flexible format of sort of team-based mental health and primary care to address some of that. So those are the things that I sit in front of my computer and stew about, like I was this morning. Yeah, so those are most of the things I'm thinking about. One of the things, that Patty asked me to talk about a little bit was what kind of research is being done at UW. So I said before that the Ames Center was involved in research, and some of the things that are interesting that are happening right now. There is a big study that's just getting ready to be published with the treatment of bipolar disorder via collaborative care in rural FQHCs. That's very exciting. I think it will make a big impact, and that's probably due out summer. But it will be, you know, I'm not supposed to talk about it too much, but it will be exciting. We're also starting a big program, a big research project with the treatment of opioid use disorder in a collaborative care setting. And that's just getting started. It's a multi-year study, and it's just getting started. So I can't really, we don't have any idea yet about how that's all going to come out. We're still recruiting the sites. We're just starting to see patients. Some of the other things that we are doing are mostly about implementation. So I've been involved with a program in California that's working with senior populations, the idea being to create a partnership between a mental health organization and a community social service agency, most of them are, and use how can I say this, a collaborative care informed process of creating a partnership and seeing how that can be used to improve the care that people get. And so this will get written up too, but I don't mind talking about. One of the really, really, really interesting things about this is that if we've been somewhat lenient about, you know, the collaborative care formula and having everybody, you know, meet all the you know, the requirements. They're not requirements, but the sort of usual guidelines. And one of the things we learned from this that's made a huge impression on me is that even in organizations that weren't providing particularly, in our view, super collaborative care, the effective addressing of folks' social determinants of health, so older folks who were isolated or who were like homeless or nearly homeless, or you know, in some way or other really in need of intervention in that way, made a gigantic difference in the outcome of their depressions. And some of them, it hardly seemed like they were getting depression treatment at all, but they would have a really useful engagement with these social service agencies who had been, you know, included in the team. And I was shocked and amazed at how useful that was. Similarly, there was another organization that did a thing where they were doing in-home care, and this was using a model called PEARLS. PEARLS is an acronym for something, and PEARLS is an in-home structured psychotherapeutic approach to geriatric depression that was kind of invented about the same time as collaborative care. And so it's a manualized brief psychotherapy. And so they had, in this one organization in San Bernardino, they were working with an entirely Spanish-speaking population, and they had folks, like bachelor's level, if that, case management folks going into the home. Again, this is pre-COVID, and doing this manualized brief treatment, and patients did awesome. So, the upshot of this is I've learned a lot about various things that work. And so that's been really, really, really interesting. So when you're thinking about like tweaking your program, if your program is stood up to make a real difference, it's clear that doing things, the kind of the collaborative care way makes sense, but that there are other really, really, really powerful kind of interventions depending on who you're working with as well. So that's really, really, that's the big thing I've learned in the last year. Yeah, so that's what I've been doing. So I'm happy to chat about any one of those things or other questions you have about collaborative care or implementation or team-based care writ large.
I can definitely start jumping in, but I don't want to take over the whole meeting. So what questions do you guys have? What made you take time to log on? And
Patty, I'll start off. This is Eric. I'd love to hear a little bit more about some of these evolving thoughts around collaborative care management and how they're supporting more diverse populations. I think in a lot of cases, people think of CoCM as this topical Band-Aid for mild to moderate patients. We certainly see a lot of higher acuity patients within our panel. So can you talk about some of the things that you've seen as far as managing complex patients and candidly patients across the spectrum?
Yeah, sure. My kind of point of view about this derives from my experience running a program, for 10 plus years, which was theoretically a collaborative care program, but we were basically responsible for all comers. And so that my experience was that was, the short version is that was doable. And so that you could provide a sort of a more typical collaborative care service for folks for whom that was useful, while still being able to respond to what was mostly, somatic treatment of people with, more major, bipolar illnesses, to be exact. So one of the things we did is we started deciding that there was no way we were going to be able to refer out for bipolar illness almost ever, because sometimes because the resources were hard to find, and sometimes because people just wouldn't go. And so we made a plan to treat them on purpose, and we had like 900. I had a series of 920 patients with bipolar, and every single one of which I made the diagnosis. I didn't see them myself, but we didn't use the historic diagnosis. We didn't use the PCP diagnosis. We staffed every one of the 920. And what I can tell you I learned from that is that bipolar disorder is harder to treat than I thought. I think that one of the things we learned, for example, is at the end of the 8 years or so that we did this, we were still only seeing about 10% of the patients that we had originally that had been seen at one time. We didn't have great measurement of outcome because I was running a program. I was not at the Ames Center in those days. I was just trying to get some patients seen and keeping track of what we were doing. So that's unfortunate. It's too bad we don't have that. That would have been really interesting. But my gut is that it's harder that when you're doing it in community mental health, people come in and you see them and maybe you stabilize them, or maybe they're more like an ongoing stable maintenance kind of case. And then if they come and they go, there's always somebody else. There's the fire hose of demand, and so there's always somebody else, and you don't have a really good sense of how many people are you continuing to treat in the long haul of all of those who had originally come in. And I think that number, one of the things I decided was that number in both settings, both in primary care and behavioral health, is a lot lower than I thought. And there's a lot of kind of people coming in and kind of bouncing off and going wherever they go, and maybe coming back later than I had imagined, and that it was that it's just harder to treat than I thought. And we could do it, and it didn't disrupt the clinic too much, and the providers who were face to face with these patients and couldn't refer them out appreciated it and were willing. One of the things we learned is they were willing, with guidance and help, to prescribe mood stabilizers and antipsychotics. And I wrote them up a little, those of you who heard me talk before, I wrote them up a little laminated roadmap for the care of bipolar disorder. And so, lamination, cures a host of evils and conveys truth. And so that, they had that to hold on to, say, what are you doing now? What are you doing now? What are you doing now? And if it was on the laminated piece of paper, then they felt like it was okay. And I wasn't going rogue. So that one of the things we established is that you can do it without completely blowing the clinic up, and without overly extending, in my hands anyway, without overly extending the capacity of the behavioral health care managers. They could do that part, and they could do the other more standard collaborative care kind of stuff. So that was so. To back up, the reason I'm interested in, and I think it's reasonable to think about an expanded collaborative care approach, is that I did it, and it wasn't terribly. I'm going to say it wasn't hard, but it was doable. So I think that if you had a planful approach to a somewhat expanded caseload, I think that would be a sensible thing to do. I think what happens in a lot of programs is that you stand up the program, and the idea is that it's going to be kind of standard collaborative care, and there's all these other things that go on, and you kind of think of them as not really your work, but you do them with your left hand while you're doing what you think is your real work with the standard collaborative care program. And it seems to me like the whole thing is our work, and it makes sense to be planful in those settings, especially in those settings where referral is scarce, to plan how are we actually going to do this, including the patients that don't fit into what we think of as our standard collaborative care approach. So that's one of the things I was interested in. I was telling Patty that a colleague of hers from Arkansas is actually working with an organization I was working with in Chicago that's doing something very much like this with a Medicare Advantage population. So it's a captive audience. You don't really refer a lot of these people out, and so how do you figure how you're going to meet all the needs of this population that has lots of different kinds of psychopathology? Does that answer your question, Eric?
Yeah, great response. I would agree that we've got to look at broadening it, really mainly for two reasons. Number one, a lot of the providers, the primary care providers in these sites, they don't want to have to pick and choose who comes to us, and so we become the de facto one, first stop.
I think that's appropriate. I actually think that's how it should run. I think they should send them to us, and we go, okay, we got it, or okay, we don't got it, we're going to refer, or whatever. But I think that having the behavioral health team make that call makes way more sense than asking the primary care provider to make that call.
Totally agree. And then the other thing we're running into is there's just a lack of community resources. So we're effectively, we don't have a lot of options to send them out. Right. So in more cases than not, we have to manage in-house. So yeah, thank you for the response.
Yeah, so it all sounds great, and so I've I've kind of kicked this around with some of the people at Ames and with Jürgen Unitzer in particular, and he says, you're biting off more than you can chew. Look how hard it is to implement regular old collaborative care, and you're going to make it even more complex. How's that going to work? So that's, so I respect Jürgen's opinion, but it is tricky, but I think that it's inescapable.
Hi, I'll
Hi,
just
Naftali. How
jump
are you?
onto this conversation. Hi, Dr. Kern. I just want to jump onto this conversation and say I 100% agree. I think the collaborative care model has such promise for, taking elements of it, the elements of it that really work really well, and broadening it out to a bunch of different populations. And I put a link in the chat for an organization that I worked at 10 years ago, like 7 years ago. And that's basically what we did. We had such scarce psychiatry resources in the community. Our community mental health center literally stopped taking Medicaid patients. In
lieu of what? I mean, in place of who are they seeing then? Like,
they were seeing only Medicaid patients who belong to a certain HMO.
Oh, geez.
And then other commercial patients. And we were an FQHC in a small, medium-sized city. This is Madison, Wisconsin. And we had tons of folks with complex conditions, bipolar, schizophrenia, schizoaffective disorder, much more than what you would typically see at a normal primary care practice. And so we were like, okay, well, we got to do something here. And we basically took principles from collaborative care, which include, let's track these folks, right? Let's flexibly interact using some care management. Let's really use our consulting psychiatrist in these episodes of care flexibly, because we understand that these folks are going to come in and out. So we know that there's going to be episodes where we might see them for 6 weeks, and then times where we won't see them for another 3 or 4 months, right? But let's maximize that so that they can get in to see the consulting psychiatrist as quickly as possible, coach our primary care providers so they take over prescribing as quickly as possible, like you said, with mood stabilizers, antipsychotics. And we really got the entire staff of physicians trained up where they felt comfortable with the guidance of the consulting psychiatrist to really help stabilize. And I think part of it is you have to have different end goals with this group, where it's not like you're going to solve all their life problems. But if you can keep someone employed for a few weeks because you got them started on a mood stabilizer, if you can keep them from losing their kids because you hooked them on an antipsychotic and are giving them weekly phone calls to check in and troubleshoot, et cetera, like that really makes a huge difference. So, and I think that's where the flexibility comes in.
I agree.
The model is still there.
Yeah, one of the things I'd noticed was that, patients would come in and they'd have a meth habit and a brain injury and probably a major mood disorder, and they were homeless and they, had a long history of, kind of misuse of the medical system. And they would come in and they, if you were to assess somebody on the front end and say, is this appropriate for our primary care behavioral health problem, you say, well, no, they're a bloody mess. we don't need to call the Mounties out to get everything that they need. But what would happen is they would come in and they would be seen 2 or 3 or 4 times by the care manager, and they would have a very good experience. They would have a good clinical experience. They would feel cared for, and they would stabilize to some degree, and they would leave better than when they came in. And often they would have gotten, a crisis would have stabilized. And so the upshot is that you had somebody with a horribly complex disorder that you'd helped. And it's not the same thing as like plugging them in permanently to some umbilical cord that's going to keep them well forever. but it was still worth doing, I thought. And I was always amazed at the impact that it would have on some of these folks. Though you wouldn't necessarily say, here's my program to take care of people with really terrible, I left out the trauma, with really terrible, multi-problem mental health problems. You haven't seen them 3-4 times by a care manager in a mental health center. You wouldn't set that, or a primary care organization, you wouldn't set that up, but it did seem to help. I'm interested, Lisa, and you had talked a little bit about kind of your expanded array at Lawndale. Can you say a little bit about what happens where you are?
Yeah, I mean, it's definitely a work in progress. I think actually Naftali was one of the founders for our behavioral health department. Thank you. And I think, we try to be able to provide a really wide range of care. I mean, kind of a stepped care model where we've got everything from, like, I try to be available as much as possible on Skype for messaging, which has really helped to have that like ease of access for PCPs so that they know if they have questions, they can contact me. And then sort of adding in like training for PCPs and e-consults, so we can address a little wider range of things. And I think we do have some care managers. It's been hard to get kind of a larger system in place for more like mental health informed care for kind of these complex cases. But I think especially to the point of a lot of complex trauma, in addition to like paranoia from schizophrenia or whatever, having those care managers being a trusting, consistent person has been really important. And so I think that's helped, with everything from, our high utilizers to somebody who's just kind of popping in every once in a while. That's been a really important piece, kind of for continuity and trust. And then this is something I wasn't really expecting when I came here, but we started actually doing a fair amount with long-acting injectable antipsychotics, because we find that we've got these folks who are just sort of popping in, or they're getting admitted and we're their medical home, so we're involved. And so being able to work with inpatient units when possible, or when they just pop in, or maybe they started MAT care for their opioid use disorder, and just being able to move as quickly as possible with them, like in the kind of the stage of change where they're at, and being able to now we've got Invega Sustaina on our formulary, so it's a lot easier to just have somebody run down to the pharmacy to get it and be able to do essentially like a DOT Risperdal trial to get somebody started with, the oral antipsychotics to be able to start the LAI. So some of these feel sort of like cowboy things to be doing, but I think with some good support and training for our PCPs and kind of me being around and available, and at this point I'm seeing some patients, so able to help with some of that. But a lot of times they're just not like engaging in kind of where they're supposed to engage, which is why they're not in psychiatry clinics. But
right.
It's really,
and then where you are, at least it's on the west side of Chicago, where actual functional public mental health is really just an idea. So you have that particular, set of circumstances. One thing that interests me about it is that, you've been able to do all this, and, and some people, can't get their PCPs to prescribe Zoloft. So I wonder if you could comment a little bit on what you think makes it possible for you to move past the Zoloft stage, in terms of your engagement with your whole medical team.
I do think some foundational parts of it is that our PCPs truly really care about their patients, and some of that I think is informed by their faith, but just a really strong commitment to start with. And then from there, I think, even, having a long history of behavioral health integrated, at least people are seeing that as part of their care. It's not just like something that you refer out to the therapist or the psychiatrist. So I think that's really closely integrated. And, having our behavioral health providers there for a long time and kind of suggesting things, obviously, they're not prescribing themselves, but that's, and then I've done a lot of trainings, and I try to, whenever I'm talking with a PCP, trying to give a little education with that and give it, my recommendations, giving like the antipsychotic monitoring stuff and like some of that that they can reference, or sending out at one point I was doing like psychiatry tips, sending out every month to give some just like kind of pearls for, this is how you use Wellbutrin, or some kind of little stuff along the way. And again, just being available, that people can ask questions if they're doing something that's outside their comfort zone.
Yeah, that's all good. That's all good stuff. You're full time at Lawndale, am I right?
I am, and I just got a second psychiatrist who's come on, so that has helped a lot because I was.
Now you can go on vacation.
Yeah. Yeah.
A long vacation. No, that's cool. That's cool.
Really
Oh,
encouraging.
I want to read Mark's. Mark says, challenges clarifying an episode of care and care coordination. We brought in definition. How to avoid filling up your care manager's caseload with folks who need long-term support, so there's no access for those needing shorter stabilization. Functional endpoints would be good. Yeah, when I was doing this, well, I'm kind of still doing it. I was kind of waiting for the point to arrive at the point where folks couldn't get in. So there was the situation you described where they were so gummed up with people who needed kind of ongoing indefinite kinds of care that they couldn't do the standard sort of collaborative care, the standard front end, and we never got there. And I don't know if it's because too many cases went through our fingers. I don't know the answer to that, but we kept waiting to get there, and we were prepared to hire like the next care manager, but it never seemed to happen. So I don't actually know. I think that's a great question. Like, how much do you need, or how, what's the resource requirement if you're going to do this expanded thing? Have you had the experience of people getting full like that?
Well, it's tricky, at least in our world. If you want to justify resources for care managers from administrators, they like to see either that they're full or that they have outcomes. And obviously they're caring about the new CoCM codes that you can bill for it, but that's helped. But what are the outcomes? And when we added bipolar for a while, our problem was, when are they done with that? When do we move a person out of care coordination to something else? And we ended up with this more nebulous definition of they're plugged in. So for the next episode, or they got someone to work with for the current episode, they're not necessarily, in remission. They might have still some mixed symptoms. They're dropping in and out of care, but free up that care manager for the next person. With depression, it's a little easier. You could say, we aim at remission. If you can't get to remission in a given time, then we discharge you because we've realized that your personality disorder, your situation, your alcohol use, well, we've clarified the problem enough, but we have at least some target, right, of what we orient our work towards. And then we realize what the barrier is to that target, and a subset can't get to that target, but some can. But how do you create your outcome for schizoaffective or schizophrenia or bipolar that you organize your efforts around, and then learn, what the barriers are, and you obviously don't get everybody there. That's the interesting thing. And I think the challenge with functional outcomes is that to have a functional outcome that you could use as a population-based measure, it becomes individually kind of less interesting or relevant, like a CVI. But to have something that's individually relevant, then how do you say how you're doing with your population? And Jürgen and I have talked about this. We've talked about whether you have a Likert scale that's individualized to each person, and then you just look at how much you move someone up on that Likert scale. And we're talking about maybe doing a little study on bipolar using a symptomatic measure versus a functional measure, and trying to see what makes sense. But I think if we could come up with something that clearly getting people back to work, keeping them from losing their jobs, keeping them off the street, we got, I think one of the real strengths of our work, theoretically, is early attention to a problem that can get huge over time because of our broken system. So if we attend to somebody early, someone with an eating disorder, someone with bipolar, someone with schizophrenia, someone with depression, and we can figure out how to teach them to manage it or plug them into where to manage it, that's a huge impact potentially, but it's useful to have a measurable outcome that then you can share with your administrators to say, I need one more care manager, I need one more care coordinator, that they understand. And I think, at least here, we're still struggling a little bit with that.
Yeah, I mean, I think in some settings, for example, if you're working like my two programs were both in FQs, and there you could say, you know, if you can generate encounters, you know, go. And you know, there's no downside to generating more encounters as long as like there was room for you or something. And so that was, and not every setting is like that. And that was one characteristic of it that was.
And I think that's where all of us often are. We're sort of in the soup of fee for service, even though we may see the limitations of that soup. You know,
Yeah.
I think that if I could create, like you said, create the clean slate and start over, I sort of think that two of the tensions that are most important for IBH are the tension between access and outcome. You know, because we can create really quick access, but then if we don't get the person to the goal line, have we really achieved something? But if we know a great outcome, you know, Cadillac service, but there's no access, it's useless too. So how do you find the right, you know, place between those two? I don't know, but it seems like we should be measuring those things across our systems and innovating around them. So.
Mm-hmm.
That's really well said, Mark. Yeah, that's the conundrum that you know, we definitely face is figuring out what those endpoints are and how do we then use those to define the step care model, right? I mean, and I think part of it is that we're all struggling with the fact that there are not steps to the step care model, right? I mean, it's like a lot of us are in situations where it's us or it's kind of not much, you know, so if you discharge a patient from your CoCM program, where do they go, right? Right. So you can say, well, patients with insurance get specialty care access. Maybe we step them up to specialty care, but even that system doesn't work terribly well, we know, right? So, and then for many of us working with folks who don't have access or really great insurance, we know that there's not a lot there. So, you know, it'd be great if we had more steps to the step care. It would make this issue a lot more seamless because we could make more individualized decisions and say, you know, this set of X number of patients on this care manager's panel, you know, they could be stepped down to primary care. They don't need us doing the extra monitoring or support. They can just check in with us. This 20 here needs to be stepped up to specialty mental health services or this particular program, et cetera. We just don't have the luxury of doing that most of the time. So I think we're kind of in a often face a damned if you do, damned if you don't type situation where we feel like we're cutting people off of care, or you know, doing a job that we don't think our model is designed to do.
Right. Yeah, all that said, you know, I think that, you know, it's kind of like it's, you know, some of what we're talking about, you know, organizing a system that will meet the needs of our population more completely. It's a great idea. I still think it's worth if you have for those of you who are in like kind of the considering implementation stages, if you have the opportunity to implement, if you have the opportunity to put in place a program of this kind, you should do it. And and you know, at some point you'll figure out, well, how much of what we're talking about can you do, or how well does what you do work? And of course, going from like getting started to a more mature program involves 1,000 tweaks, and you're going to be doing that anyhow. And so if just for those of you who are on the call, I wouldn't let myself get discouraged about not having a perfect plan that does everything, because there is no such perfect plan. And yet the work is worth doing. And the access that you create for folks is real access. And so I think that, these kind of things that we're talking about are of great interest to me, and I would like to be able to say, oh, we figured out a plan for taking care of everybody we need to take care of, but that we're not there, and yet it's still worth doing. Just not to get too discouraged by the complexities of it. It's still worth doing in my view.
Totally agree.
And while we do it, we'll get more experience and figure out what works and doesn't work. And like, some of the things I was talking about before, like, if you'd said, oh, how helpful is it to have people go out and, make sure people have their, their food stamps and their rent is paid, I would say that doesn't have that much to do with the treatment of geriatric depression, but, I learned something from that experience. All right, well, we're close to done, unfortunately.
And we're out of time.
Yeah.
Kevin did put in a question about some of the implementation research. What are the outcomes of interest? I don't know if you can make a quick comment on that, or if that's something we need to.
No, but Kevin, send me a note. I can reply to you. Or Patty, you can help organize this. I appreciate it.
Yeah.
I'm happy to reply. But
yeah, if you want to send it to me, and I'll forward it. And Kevin, be sure I have your email.
Thank you.
All right.
Well, this has been.
Thanks a lot, everybody. It was fun.
Thanks.
Thanks, Patty.
John.
Bye-bye.